Good morning, everyone. Thank you for coming at this early time, especially after the welcome reception last night. I think there was a lot of frivolity happening. So, my name's Andrea Schroeder, and I'll be chairing this session. I'm a bariatric nurse from New Zealand, and I'm very privileged and honoured to be able to both chair and speak in this session this morning about what we've learnt from our patients that have changed our practice. We've heard over the last few days about the impact that we can have on our patients if we show them understanding, we embrace their journeys, and we look forward to this morning learning more about what our patients have, how our patients have taught us to be able to care for them in an understanding and compassionate way. So my moderators this morning here with me, I have, I'll just go right to left, left to right, your way. So we have Richa Jaswal. Yes. And Richa is a dietitian from India and very active in the Indian Obesity Society. And she is also one of our Integrated Health Scholarship winners. The second of our moderators is Dr. Poonam Shah, and she was the first bariatric physician, and she's been doing this for 20 years, and also the first integrated health member from India. And then lastly, we have here Mary O'Kane, who's a very experienced dietitian from the UK, and she's the current president of the Integrated Health section, and she'll be handing over the role this meeting to Sylvia. And she's done a stellar job of setting up the Integrated Health as a section now. So we look forward to this morning. So thank you.
Right, so we start with the So good morning, everyone. Let's start with our session because we're already 5 to 10 minutes late. It's my pleasure to introduce Radhika Milin Shah as the first speaker. She's a registered dietitian. She's working with us for more than 8 years in our bariatric unit, and she has presented at various international platforms like ASMBS and IFSO. So she has an interesting topic to present. Radhika, please start.
Very good morning to one and all, and first of all I would like to thank IFSO for giving me this opportunity, and I would like to congratulate the integrated team for this wonderful and a very interesting session, because yes, even I do believe that we learn a lot from our patients, and I have witnessed it, and I'm going to share one of my experience, that what I learned from my patient in my past 8 years of practice in bariatrics. And before I start, I would take this opportunity to thank my proctors and teachers who taught me that the role of a bariatric nutritionist in a bariatric unit is just beyond calculating calories and proteins. And this is a small picture of my fellowship. And in past 8 years, I have come across around 45,000 patients, and I have witnessed them getting better and better. However, I have come across 8 to 10 patients who were above BMI of 100. But I would like to share one of the very unique and interesting case where probably all the modalities of the treatment were used. And it was the first day for me and first day for this lady in the hospital. Lady with BMI of 133. For the first time I had heard and seen a BMI in 3 digits. So let's see how we prepared her and journey of this lady. All the newspapers in India and Asia were flooded with the news of a lady losing 215 kgs weight and maintaining at the end of 5 years. This is just a pictorial representation of a lady from 300 kgs to 85 kgs at the end of 5 years. Let me just take you through the history of the patient. She was a 42-year-old lady with weight of 310 kg, Asian Indian vegetarian lady, and BMI of 133. All possible comorbidities that one could imagine were present here, like she had diabetes for 4 years, renal failure with a solitary kidney and creatinine of 2.4, obstructive sleep apnea, and she was bedridden for almost 8 years and had not seen the outside world for almost 10 years. She was breathless. Needless to say, her oxygen saturation was dropping and was around 80 to 85%. We all here are aware of the standard preoperative preparation of very low calorie diet, pulmonary preparation, etc. And all this to minimize the operation room time. However, in the patients above BMI of 100, it is different because BMI above 100 is a separate disease entity. Due to the huge body size, these patients are often non-ambulatory or very less ambulatory, inducing the chances of deep vein thrombosis, embolism, acute renal failure, rhabdomyolysis, multiple comorbidities, and anasarca due to anasarca, non-compliant abdominal and fat-laden wall. Let me throw some light on rhabdomyolysis, which is fortunately very uncommon but could be seen in patients above BMI of 100. It is a breakdown of muscle fiber releasing creatinine kinase and myoglobulin into systemic circulation, which affects the filtering function of the kidney. In such patients, this muscle trauma could be due to their excess weight falling on the muscles. Of course, patients above BMI of 100 are at higher risks, and prolonged OR time can give rise to rhabdomyolysis, and early identification can prevent patients going into risk. And hence, rise in creatinine kinase, electrolyte imbalance, decreased output, muscle pain, specifically in buttocks, hips, and shoulder, pelvis should be identified by the healthcare professionals. Now, what is the role of a bariatric nutritionist here? It is hydration during pre, peri, and post-operative, good ambulation with good preparation, and of course, reduction in OR time, which is in the hand of nutritionist, I believe, with a very good preparation, and monitoring input, output, and proper padding during the procedures or during when the patient is lying down. And one more additional tip here for all the professionals is routine preoperative creatinine kinase is supposed to be added for BMI above 100. Because the complications were different, the goals of the preparations were different, massive preoperative weight loss is expected, and in this case it was around 15%, which is equivalent to almost 50 kgs, and I think everyone would believe, we all think that losing so much of weight is only possible after a bariatric surgery. Reduction in anesthesia risk, excellent pulmonary capacity to be achieved, ambulation to be achieved, and all this in order to reduce the OR room time. Patient was evaluated for all endoneuro causes and they were normal. She was severely obese, or she was suffering with severe obesity since her childhood. She had crossed 100 kgs of weight at the age of 14 only. And all this made her impossible to move, and ultimately leading to bedridden patient. Let me throw some light on some abnormal investigations, like creatinine was on the higher side, HbA1c was 7.2, her USG showed grade 3 fatty liver, which was of course suboptimal due to lot of fat pads, and she had pulmonary hypertension, and pulmonary function test showed severe restriction. We did CPK, and which was normal preoperatively. Renal, diabetic, very low calorie diet, which is acceptable, palatable, and sustainable for over 1 month with a good nutrition care. I suppose it's a challenge, and every nutritionist sitting here would agree with me that even for a short duration of preparation, it is a mammoth task, and here we had to prepare her for almost 1 month. Some dietary challenges, and what we learned is, in such patients with higher BMI, calculation of per kg body weight doesn't apply, like especially in patients with 300 kg. Renal, very low calorie diabetic diet is not always very acceptable and palatable, and no matter how qualified a nutritionist is, lot of innovation is required, and it's not a job of only one nutritionist in a clinic, and hence in such preparation a team of nutritionists is required. We practically design all courses of the meal for this lady, right from the starters to desserts, comparatively very low calorie. Some cheat days were of course allowed for this lady, and it was really a mammoth task. Addition of some protein supplements, which I am going to talk in the renal challenges. Coming to the renal challenges, to remind, she had a solitary kidney and creatinine of 2.4. However, her urine output was really good, and because of anasarca, she was on high doses of diuretic, and hence the fluids were permitted freely. Electrolytes were monitored, and every alternate day and corrected as and when required. Protein calculation for this lady was done by the nephrologist, considering proteinuria, which she had, I missed telling you in the previous slide, but she had a proteinuria, she had solitary kidney, and her creatinine was on the higher side. Considering all these parameters, the calculation was done by the nephrologist. Being Indian vegetarian, to achieve 35 grams through very low calorie diet was again a challenge, and we added one protein shake for this lady. So along with that, another challenges that you can see is excess weight. Ambulation is a challenge due to excess weight, edema, severe pain in knee joints, and long period of minimal ambulation. And you can see her struggling to get up, but we used to make her walk at least few steps every day. At the same time, way back in 2015, we were working on an RCT with pharmacotherapy plus low calorie diet versus very low calorie diet, which was eventually presented in IFSO 2017, and this was a savior for us as well as for this lady, because we added 1.2 milligrams of liraglutide in preoperative preparation for this lady. Now, the point that I want to give here is drug-related modification is very important for a dietitian to know. Drug-related dietary intervention. Liraglutide, as we all know, can lead to sometimes causes delayed gastric emptying, causing some constipation, sometimes nausea. So it is a role of a nutritionist, though you don't prescribe the medication or we don't prescribe the medication, it is the role of a nutritionist to understand and counsel the patients for the effects of the medications, so as to understand them that it is not the side effect. Nausea, delayed gastric emptying, constipation, sometimes acidity and modification. Here we added fiber supplement for this patient along with the protein supplement. Giving small frequent meals, addition of liquid diets, etc. is very important. Now there are a lot of medications available in the market, and we should be aware of every medication. Daily monitoring for these patients are important. Here all the abnormal parameters were monitored, and for 45 days. I believe it is a multi-speciality approach than just a multidisciplinary approach in this patient, and all the specialists, including the nephrologist, pulmonologist, bariatric physician, team of a nutritionist, and of course team of physiotherapist is required, because it's not a job of one physiotherapist to make this patient walk or do exercises, and bariatric psychiatrist and psychologist are equally important. Day 45, the most awaited day for the patient as well as for the team, the day of her surgery, when she was prepared, she got clearance from everyone. You can see that she started taking 100 steps a day. She started walking with great difficulty, but she got clearance from every specialist, and this is the video of her surgery. Can I have an audio, please, for this? You can see her sleeve gastrectomy.
No. And how was your experience with the surgery, post-surgery? How are you feeling?
I don't feel like I have gone through surgery.
Yeah?
This was immediately on day 1 of the surgery, and what else a team would expect? A patient with BMI of 300 says that she doesn't feel as if she has undergone the surgery. Of course, the credit goes to the operating surgeon who is here, Dr. Shashank Shah. The surgery got over in just 30 minutes. However, the entire OR team complimented the integrated team for the good preparation. She was discharged on day 10, and all the parameters were monitored regularly, and you can see at the time of discharge, she is walking alone on her own. What is a very important tip here, that these patients might not be able to come to the clinic very often for follow-ups due to their big size, but it is our duty to have some online consultations, follow-ups. Sometimes from our team, because we have a big team, a nutritionist and a physiotherapist did visit her in the initial phases till she was ambulatory and could visit for frequent and regular follow-up. This is her journey from 300 to 85 kgs. She underwent sleeve gastrectomy at 251. At 130 kgs, at the end of 2 years, she underwent 1 anastomosis gastric bypass, and she came down to 89 kgs. And after that, after 1 year, she underwent abdominoplasty, and today she is maintaining after 8 years at 85 kgs with some pharmacotherapy. There are various case reports of patients undergoing bariatric surgery with the weight of 300 or plus, but probably this is one of the massive transformation that I have witnessed in my life. So 5 years later, this is a video, and she started leading normal life. She started going to shopping, started earning, and her quality of life changed. She started taking care of her family, and this is a true satisfaction, I suppose.
You know where are we? We are at Vasai Fort.
And she could climb a fort after 5 years itself is a success, I believe. The best certificate of her psychological improvement was she herself conducted a press conference and got us India Book and World Book of Records. So what I believe and what I learn is prepare, prepare, and prepare. And prolonged preparation is the key for the success. Multi-speciality and disciplinary team is the is very important part of the success story for such patients. And there is no secret for success. This is a result of hard work, persistence, belief in the science, and learning from the experience. And I believe that all the healthcare professionals should believe that nothing is impossible. There are various papers we searched, but there are no papers which were published for BMI over 100. However, some interesting papers I would like to quote. This paper focuses more on the organizational challenges that are faced by the organization when such patients visit the clinic. However, we could overcome. I'm going to tell the reason how we could overcome the challenges in this lady. This is another paper which focuses on need of multivitamin supplementation for these patients prior to bariatric surgery, because it's a long duration preparation. I would also like to make a point that we add ursodeoxycholic acid for these patients when they are on preparation, because long duration preparation or any kind of weight loss can induce gallbladder stones, and this is a massive weight loss prior to surgery. Another paper which says that around at the end of 14 weeks the weight loss stabilizes, and it's the time for the surgeon to take the patient for surgery. However, we could achieve it in just 45 days. It's a very interesting paper by IFSO. It's a survey of 789 expert surgeons across 73 countries, where even this paper didn't mention anything about BMI over 100. However, one point that all the expert surgeons said, it is at least 10% of the weight loss should be achieved prior to the bariatric surgery for severe obese patients, and we could achieve around 15%. He is a British gentleman who came way back, I suppose in 2008 to the clinic when I was not even practicing bariatrics, but I learned from the experience. That time we had some organizational challenges. So you can see 2 beds required, the sofa, double bed sofa bending in between, and then practically a OT table was designed for him. But even at that time, he was prepared for long duration, probably with less or without any pharmacotherapy. Long duration, the team was exhausted, patient was exhausted, but still he was prepared well, and you can see the ambulatory anesthesia. He thanking the surgeon right on the OT table, and this is the picture after 12 years when he is a fitness person now. This is another entity. You can see a big abdominal wall which is called as anasarca, thick wall like a stone. So these patients need lot of diuretics preparation. It's a complete different preparation, and these patients are supposed to be prepared in hospital. You can see after 5 weeks the abdominal wall has become soft. Another patient with just BMI of 78, however, if you see the waist circumference or visceral fat, it is quite high, and such patients should also be prepared like patients with BMI of 100. Huge anasarca, cellulitis, abdominal wall was almost unfavorable. She was prepared, and she was just BMI of 82. 110 BMI, if you see the lateral diameter is around 4.5 feet for this patient. Only one tip here, even the patient was extubated in the lateral or sideways position. So there are various papers that say, or there are various patients that I have come across. Only 2 points that I would like to say, and I would end my talk, is inpatient preparation or supervised preparation is very important. BMI over 100, or maybe I would say above 80, is a separate disease entity, and all the modalities of the treatment should be used. Creatinine phosphokinase should be investigated. as a routine in such patients. An integrated health team should be aware of all the other branches of medicines and therapies while preparing such patients. Success is best when it is shared, and hence I am here, and I would like to thank IFSO for giving me this opportunity. Thank you.
So Radhika, that was very well covered. We'll have the question answers at the end of the discussion. As a physician of that unit, I just want to add that at that time there were the pharmacotherapy options were not much available. So except for liraglutide injectable, we haven't used anything. And at that time, the safety of SGLT2 inhibitors was also not known with the patient with a single kidney and with proteinuria. So we can discuss this later. Thank you, Radhika.
At the outset, I would like to thank IFSO and Mary for giving me an opportunity to be on the dais. And with this note, I am going to invite Jumana Basit. Sorry for the wrong pronunciation. She is a registered dietitian, and she is from Jordan. She is going to speak on counseling Gen Z. It's interesting, and how it is different than the normal generation.
Hi, everybody. Hello. Hi, everybody. I'd like to introduce myself first. My name is Jumana Bashiti. I'm from Jordan. And in the beginning, I'd like to thank IFSO for the scholarship and the opportunity to be here and to meet all of you and to learn from your experience and hope, share some of my humble experience in the field of bariatric surgery and obesity. So, when we were discussing the topic of this session, and we were thinking about sharing an experience of a patient that changed our practice, it was, it hit me immediately that there's this one patient that I encountered last summer, actually, and it was really such an insightful experience to deal with what happened with this patient, and so. After this patient underwent surgery, okay, sorry. Before we begin, I have no disclosures. Okay, so let's begin before we start talking about the patient. Let's begin to define Gen Z. So for those of you who don't know, Gen Z is the generation born between the late 90s and the early 2010s. So in 2023, their age ranges between 13 and 27 years old. So some of them are still in middle school and high school, and some of them are, university and or just beginning to join the workforce. So when I looked up, information about Gen Z, and based on my personal observation, they are a generation who are, born with technology between their fingertips. They are technology natives. They're born with, tablets, iPads, cell phones. They have very easy access to information. They can just, they have their phones with them, and they Google everything within minutes, and they can easily find the information they want. They're also individualistic and very independent, so they are very opinionated and they value their independence. They're not really likely to conform to social norms. They value career development and their identity and becoming something in the future. I don't know, this might be controversial. I don't know if it's really backed up by science, but they're known to have shorter attention spans. I think this is because of the amount of media and information they consume, through their phones and social media and all of that. So, ideally, if someone consumes a lot of media, it kind of really affects your attention span. And a lot of them are relying more on social media for health information. And this is, even my generation does that. I'm a millennial, and we do that sometimes. And I notice a lot of my friends who do that. So this is common more and more, not just within Gen Z. But what's significant about this generation as well? So late 90s to early 2010s, we've noticed huge increases in rates of overweight and obesity, and even it's expected, like when we see the extrapolated numbers for 2030, we're gonna it's gonna even rise even more. So this generation is in the midst of the obesity epidemic, and there's a lot of societal focus on weight and dieting behaviors. A lot of my Gen Z patients have been to a dietitian who are struggling with obesity, have been to a dietitian, starting the age of 9 and 10, and it's not uncommon. And unfortunately, some of the dietitians they used to go to are not familiar with the disease, so there's a lot of blaming, a lot of lack of understanding of this disease, and just it's really terrible, like what stories I used to hear about, like dietitians putting these young kids at just 9 and 10 years old on very strict diets and being blamed and just not being understood very well. So most of our bariatric patients who come to us at 21, 22 have been traumatized a little bit by the dietitians, diet culture, and even society. A lot of the Gen Z patients we see are very much influenced also by food labels. They are very aware of dieting trends and healthy eating. The new diet on the block. There's always a Gen Z trying to incorporate that. So they're more likely to be influenced by labels such as clean ingredients, organic, plant-based, etc. So now let's talk about the story that changed our practice. So last summer, we had a patient. He's 18 years old. He's a male. He just graduated from high school, and he was about to leave Jordan to go to university. And within that summer break, he underwent a sleeve gastrectomy. And we thought we had prepared him very well. I personally take so much time educating and really counseling these young ages. And so everything went well with the surgery. The patient traveled to Spain for university I think 3 weeks after the surgery. He was stable, everything was fine. And then we start getting calls from his mom and his parents saying that he's, experiencing vomiting and severe nausea, and we just didn't know what happened. And then things start getting worse overnight and over the 3 days after receiving that call. And then we realized after, bringing him back to Jordan and really investigating that this patient did not adhere to the diet stage where he was at, and he ate like a junk food meal within the end of the phase 2, which is the mashed food diet, and he developed gallstones. And we really discussed and reflected, the team and I, what happened with this patient, is who's to blame, or we were not really trying to blame, but we were really reflecting on what happened. And then we realized, at least I realized, that this age group is really, really sensitive, and maybe we should reflect on the way we approach these patients and the way we counsel these patients to make it in a way that is more appropriate to, their way of thinking. Because we were treating them as if, at least it was just like autopilot, counseling and everything. It was just, standard for everybody at each age group. So we realized that we need to do something different. So this is what kind of triggered a little bit of changes when it comes to dealing with this age group and this generation. So the first thing that I would advise you from this experience is, first of all, when we're counseling Gen Z, we really need to integrate technology into our intervention. So if you're a bariatric dietitian, I would highly advise you to integrate some technology, because they really like their tech natives. So I would integrate some nutrition apps, wearable devices, telehealth solutions that can really help track their progress and their dietary habits more effectively. They really enjoy that. So using like the water tracker app or the water reminder app or some other bariatric apps that we can discuss later can really, really help, make the transition easier. Even though we say that telehealth solutions are really good, Generation Z still prefers the face-to-face interaction. So that does not replace the face-to-face interactions, but it's just they like, and there's a lot of new tech apps and technological integration in the world of bariatric surgery as well. Number two would be making the information bite-sized and visual. So I cannot stress this enough. So before, this patient actually received the older version of the information and the pamphlets that I used, and it was just so long and wordy and with little graphics. So I really revamped everything, not just for this, for Gen Z, for everybody. Like, we're just so overloaded with information all the time, and we consume a lot of information through our phones. So we really, nobody has the time and patience to go through a 20-page pamphlet with no graphics or no tables or no infographics. So I really recommend making the information or the pamphlets or the educational material as small and short and straight to the point as possible. Really using even short videos and interactive content to really kind of make complex ideas simple. Number three is fostering peer support and virtual peer support. So these patients, usually Gen Z, have a lot of access to social media platforms and podcasts and all of that, and they really you really want to make sure that you promote or at least encourage positive online interactions. Really guide them towards groups and online groups that are more positive and provide positive and correct information rather than kind of going on TikTok and getting bariatric surgery information from that platform. Not that it's all not scientific, but at least it's really dangerous to. So they can actually get a lot of support, but it's better to encourage getting information from reliable sources, because it's a double-edged sword, I guess. Number four, I would use personalized and data-driven approaches. So Gen Z loves personalization, and I guess it applies to everybody. They kind of like, everybody likes something that is personalized to them specifically. But here's where the trick happens, is actually explaining why it's so important to make these changes after surgery, or even just for the treatment, non-surgical treatment of obesity. It's very important to give them ownership and responsibility, as well as explaining the necessary changes in the context of health and how their life is going to be better. So yes, I think this is very important, as well as tailoring the intervention with their preferences, their cultural background, and genetic predispositions. I think this is very important as well. Flexibility and adaptability. So this generation is fast, is on the go. Most of them, so if they're in the workforce, they're working, they have entry-level jobs, they're working a lot to prove themselves, they have very busy schedules. If they're still in university, it's very challenging, and the level of stress is really high. So you really want to give them an intervention that is applicable, it's adaptable to their lifestyle. So maybe this is where we kind of missed it with the patient that that I mentioned, is that maybe we weren't as thorough in explaining how he's going to be integrating these changes, into his early university weeks. And so this is where I started reflecting. So providing on-the-go meals, travel-friendly options, strategies to navigate like social events and all of that. Also, like just dealing with comments and trying to understand where they're coming from and the challenges that they face. Number 6 would be providing a lot of psychological and emotional support. Even as a dietitian, we can still, tap into that. They are very aware, this generation is very aware of mental health and the importance of, mental well-being, and a lot of them are already, they take specific actions towards, taking care of their mental health. So I always address issues, whether it's pre-op or post-op. I always address body image changes and body image issues, self-esteem, emotional eating, and the most important thing is basically the relationship with food, and trying to assess that before and after surgery and getting an understanding of their relationship with food, and if there's any issues with that. So I think it's great to really tap into the psychological and emotional well-being, as well as incorporating stress management and mindfulness exercises and mindfulness techniques to facilitate this holistic approach. So try not to kind of focus just on the diet phases and the diet intervention. Really make it a holistic intervention. So, in conclusion, our approach to Gen Z must be as dynamic, as forward-thinking as this generation. They are the present and they are the future, and we really, honestly, I recommend integrating technology, but at the same time, not forgetting that, relationship with the generation, with the patients, working on also personalizing the preferences and making sure that you understand, because a lot of the patients that I see are also coming from, households where the parents are, either blaming or helicopter parenting, and it's just, I feel like this is also something that we should avoid. So we need to kind of make sure that we're not using the same approach as some of their parents, and just really try to understand and, help them lead a better life, and just improve the patient outcomes. Thank you.
Thank you, Zumana. Very interesting presentation and a lot to add on it. Just to stay with us. No, so, I mean, the next speaker.
Jumana, we're taking questions at the end in the discussion, if that's okay. Yeah, thank you. Thanks. So I'd like to introduce our next speaker, Andrea Schauder, who will be well known to many of you. Andrea's been on our IFSO Health Committee and now new section, and also delighted to say that she's actually our new president-elect, and she's a very experienced bariatric nurse as well.
Thank you. So my talk was originally called What I Learned from My Patients That Really Changed My Practice. It was never about the food. But once I started getting into it, I thought it's not always about the food. Sometimes it's about the food, but regularly it's not about the food. And it's not just about the surgery either. I have no potential conflict of interest. Okay, so let's get straight into it. What I learned from my patients that really changed my practice. So my patients taught me that the honeymoon ends. The magical effect of the surgery sometimes diminishes as early as 9 months. I know we regularly talk about 18 months, 2 years, but from the patients that we see, I know that when we talk to them all the time, that their struggles start to come back as early as 9 months. We also know that self-care, self-awareness, and self-love is not intuitive, and this needs to be taught and it needs to be experienced. They need help to address factors that contribute to their weight gain in the first place, and ongoing follow-up and community or team-based support is needed. So for people who don't know what we do, we actually run a residential retreat program. So as part of our follow-up, our patients come and spend 5 days in a residential program in a lodge that we run, and we live with them for the 5 days and we teach them a whole lot of things. So this video here, it's quite a long video, but you won't hear me asking the questions, so you'll just hear the responses. But I asked them things like, what are your fears about coming to the retreat? What were the highlights of the retreat? Would you recommend coming? And we use this video to help other people who come through our practice to not feel the anxiety about coming along with us. So I'll play this now. It is a 7-minute video, but it has got a lot of information that I needed you to hear.
Coming to the retreat, to be completely honest, I was extremely anxious. I didn't feel I needed to come here. I felt that I'd had the operation. I've lost the weight. Why do I need to be here?
I didn't want to come, and I wouldn't have come if I hadn't been paid for as part of the surgery. I was expecting to be lectured to.
And I was really frightened that the reality of living 4 days of what I should be being like right now was actually going to be pretty hard.
I knew that there were going to be some hard things to face up to. There were going to be things I wasn't going to like because I had to face up to the hard things. There was a reason I got to the weight loss surgery.
I felt like when I came here, I think I was a closed rosebud, for example, and now after the 4 days, I feel like that rosebud is completely opened, it's been watered, it's been fertilised, and it is growing beautifully.
I feel really embarrassed now by how resistant I was to coming, and I've gone away from here feeling, well, I will go away from here feeling amazing.
And it's been such a privilege to be with a fascinating group of people and the experts that we've had who have an amazing open attitude towards who you are and what they can learn from you, and there's never a moment of blame and shame.
I think one of the strengths of the retreat here and with the group that we've had is that we've developed a really strong trust between each other, and it's that trust that has enabled us to be able to share the really hard stuff, to be able to dispute some of our crap beliefs, and having a group that actually says, but that's not you, even though we might believe it, that's actually quite a powerful thing.
The people here have been the least judgmental people I've probably met in a long time.
The team is amazing. You just feel love from the team, and I now feel like I've got a whole bunch of new friends.
The food and being taken care of so beautifully by the staff.
And we've shared laughter in the spa pool and wonderful chats. And
strangely enough, even though David says it's optional, in your head you know it's not, but it is optional. It's jumping into the river that you know is snow melt and that you know will be freezing cold, and it is, but it's quite exhilarating, and the camaraderie that we had and the support for each other for those that chose to take the plunge, literally and figuratively. There was so much support there, and it was another part of building us trust with each other and us as a team.
I feel I'll be different in the fact I've learned to be a lot more mindful about things. It's reinforcing why we've had the surgery. It's the why. It's the mind, body, soul part that I thought was completely irrelevant, and you will learn on these 4 days it is the most important thing.
I understand a little bit more about why I've got fat, and a little bit about how I have tried to protect myself, and understand a bit about how the brain works now to protect you, and I need to work on that and work on turning that protection into awareness and letting it go, and working on stuff that will work for me.
I feel empowered to take better care of myself and to put some of the tools I've been given slowly and carefully into place so that they stay.
I feel like I can put some of my past to bed and accept a new me, and take away some some strength, some amazing support.
And my limiting beliefs have been challenged, my values, working out my values and how they impact on my life, and the crappy thoughts that I tell myself, how they impact on me. I've been given tools to notice them and then take some action.
I've definitely got more tools up my sleeve, a lot more motivated, leaving with fantastic ideas on meal ideas, which was where I was struggling, and just knowing that I've got all the people here to fall back on should things go wrong. Just so much support.
I think I'll be a bit more open, a bit more honest, and maybe put myself first more than I have for the last 40 years.
And would recommend it. I believe it should be a compulsory part of having the surgery is coming to do this. You will connect with people and have that shared experience. You feel at the time that you may be doing this alone, but you will quickly learn that every single person that's had this surgery has gone down the exact same path. And so you've all got these shared experiences. And yes, everyone's slightly different, but to connect with those people on a deeper level, I think offers so much more, and my cup is completely full after these 4 days.
Yeah, I'd recommend it. Yeah, it's absolutely essential. Anybody that's doing bariatric surgery and not having this, I think they take a big risk that they can be able to fix it, to be honest.
An opportunity to look at yourself for you, for nobody else but you.
I would definitely recommend it. I was really fortunate to have it as part of my package. There's no way I wouldn't have come. And it has exceeded my expectations.
Definitely worth coming and definitely recommend it. Can and have. We haven't even finished yet. I've already messaged several people who were concerned about coming and told them that they would be crazy not to.
Oh, more than 100%, 200%. Look, it's something I'll probably come back to one day. It's been fantastic. And yeah, look, 10 out of 10.
Okay, so I know it was long, so thanks for bearing with me through that. So in terms of my experience, you're probably thinking, why as a nurse, have I got such a psychological approach to what we do? And I think as a nurse in our practice, we're probably one of the least scary disciplines, and often our patients don't want to talk to the psychologist or they don't want to talk to the surgeon because of the shame and feeling judged. And so over 24 years of doing this and listening to my patients, they would often talk to me about the struggles that they had, and they talked about their their shame, the stigma, the family situation, the trauma that they'd experienced. So 12 years ago, we started these retreats, and we started them as back on track. And then we realised after doing them for 2 years that actually what we were teaching our patients was not how to just get back on track, but we were teaching them the foundations of healthy living. So we changed the name, and we've been running these retreats since then. The other things that we do as part of this, and what our patients have taught me, is that they do need a lot of support and community events. And so we have a pretty comprehensive practice that has things like monthly Facebook Lives. We have monthly walk and talk support groups. We run these retreats every 2 weeks. So as I said, we've been doing them now for 12 years, and we did our 100th retreat in July last year. All right, so the mantra that we have at our retreats is that we don't heal in isolation, but we heal in community. And what we know, what our patients have taught us, is that if they're in a group therapy environment, they feel much more supported and they learn much better. So our objective for our retreats is just to provide a safe environment where our patients can acknowledge and unpack their history, any potential traumas that they've experienced, and be supported by like-minded participants and facilitators who understand. And 3 of our facilitators have actually also had bariatric surgery, so they also have the lived experience. The teachings at the retreat are very acceptance and commitment therapy and cognitive behavioural therapy based. So the tools and strategies that I've got there that we teach are things like values, mindfulness, meditation, they're the ACT things, and then things like limiting beliefs. We also talk about some of the polyvagal theory stuff, which is the fight, flight, freeze, and just all the different sort of behaviours. We also cover normal healthy habits, so we talk about nutrition, we eat according to our guidelines, we encourage portion control, we do exercise every day, and we also supply vitamins and supplements. We have done a research article on this, and it has been submitted for publication at the moment. So in conclusion, the honeymoon period does end, and our patients who've had bariatric surgery will need comprehensive support and follow-up for at least 2 years afterwards, but preferably for life. It's not just about the surgery. A community-based support and follow-up program is imperative, and it's paramount to their long-term success. Wraparound care is essential, and it's not negotiable. And we must treat the biology, physiology, and the psychology. So in summary, what I learnt from my patients was that it's not about the food very often, but as the food has been the source of self-soothing, comfort and happiness for many years prior to surgery, if we don't teach our patients more healthy ways to cope with the effects of trauma, adverse events, crises and triggers, then we're setting them up for struggle long term. So I think the challenge is that we need to progress from a biomedical model of health to a biomedical psychosocial model of care. Thank you.
Thanks, Andrea, for an excellent presentation, and I think we'll want to come on the retreat. So I have great pleasure in introducing Dr. Sami Shith, that's all right, who's a psychologist in the Department of Medicine and the University of Padua in Italy. So great to see you.
Okay. Good morning. I would like to thank the organizer for this opportunity. I'm a psychologist and I work at the University Hospital of Padua. And I'm here to present a talk titled What I Have Learned About the Mental and the Behavior of Bariatric Patients. Sorry. Okay. There are no potential conflict of interest to declare. First of all, we know that there are 2 main systems regulating eating behavior in humans, and a homeostatic system and an hedonic system. The homeostatic system has the purpose of maintaining energy balance of the organism. This system is driven by several hormones from the gastrointestinal tract and adipose tissue, such as insulin, GLP-1, PYY, ghrelin, and leptin. The center of this system is in the hypothalamus, in particular the lateral, ventromedial, and arcuate nuclei. The homeostatic system regulates the sense of hunger and satiety. On the other hand, the hedonic mechanism is composed of 2 main components: the mesocortical limbic dopaminergic system and the lateral prefrontal cortex. The mesocortical limbic dopaminergic systems modulate the experience of pleasure and is involved in reward and associative learning. This system is linked with the activity of the ventral tegmental area, the nuclei accumbens, the ventromedial prefrontal cortex, orbitofrontal cortex. This part of the hedonic system, when stimulated by an external or internal cue, based on this science, automatically activate behavioral patterns that in the past had generated a gratification associated with pleasure. For example, if I repeatedly eat a particularly palatable food promoting dopamine release in the VTA nuclear accumbens, resulting in a rewarding or pleasurable experience, the association between this food and the behaviors necessary to obtain it are reinforced. At this point, every time I see that food in the future, the system will automatically activate the appropriate behaviors to obtain that pleasure sensation again. The lateral prefrontal cortex, on the other hand, is the seat of executive functions and is involved in working memory, the monitoring of voluntary action, attention, reasoning, planning, and decision-making. Additionally, this system exerts its inhibitory control on automatically generated behaviors when more adaptive options are required. For example, where we want to limit the ingestion of palatable caloric food or interrupt a meal before satiety when we are engaged in a diet. Obviously, the mesocorticolimbic mechanism motivate behaviors even in the when energy imbalance or hunger are transmitted through gastrointestinal hormonal signal reaching the homeostatic system. However, this process can guide eating behavior even in the absence of energy deficit and hunger. In many situations of daily stress or deflected mood, individuals may experience an uncomfortable feeling of internal imbalance, which they obviously wish to suppress as soon as possible. In these cases, eating behavior can be promoted automatically to mitigate the discomfort experienced in respect of hunger. Moreover, eating without hunger could be triggered in many amenable situations. For example, when we have dessert at the end of our restaurant dinner, in this instance, it is certainly not hunger that makes us want to eat that dessert. In recent years, many studies have suggested that in obese individuals, there is a neurocognitive imbalance between the two components within the hedonic system. In particular, an increased sensitivity of the mesocorticolimbic dopaminergic system toward food-related stimuli and lower inhibitory control over voluntary behavior are suggested. This imbalance generates higher impulsivity toward immediate food reward, higher attention bias for food cue, and lower cognitive control and response inhibition. All these factors contribute to the development and maintenance of the obesity condition, favoring the loss of controlled eating and impulsive behavior toward immediate food reward. Also in our lab, we observed that obese individuals seeking bariatric surgery show steeper discounting of food values during intertemporal decision-making and higher interference of food stimuli during choice erection times compared to normal weight individuals. In their personal history of weight loss attempt, patients with obesity have often felt anger and frustration, seeing that losing weight takes time and requires perseverance in maintaining healthy eating behaviors, while they obviously desire a significant weight loss quickly. Diet and physical activity are experienced as constraints that require commitment and effort. For these unattractive reasons, the idea of immediately gratify oneself with food is reinforced. Although many diets have been effective in promoting weight loss and maintenance, and that weight regain mostly follow the abandonment of the diet rules, patients develop the idea of not being able to exercise any control over the objective of lose weight through their actions. Reducing, monitoring, and leaving room to more automated, less aware behaviors oriented toward immediate gratification, which are also able to reduce the discomfort generated by weight regain. Patients can alter periods in which they do not pay any attention to their food-related behaviors, to others where they renew their motivation toward diet and lifestyle, and then abandon it and fall back into unhealthy behaviors again, and so on. This vicious cycle contributes to the occurrence of the so-called weight cycle. In turn, it generates frustration in the patient, favoring the loss of control and the activation of impulsive behavior toward food again. A psychological consequence of is the development of low self-esteem, depressive symptoms, and feeling of inability to reach the goal of losing weight and maintaining a healthy lifestyle. The social stigmatizing and stereotyping toward people with obesity have the effect of promoting and enforcing negative self-judgment that makes them feel inadequate and experience the condition as their fault. It should be emphasized that patients with obesity are frail individuals of higher risk of suffering from depression or of having an eating disorder. However, even in the absence of an objective psychopathological condition, high level of psychosocial distress and impulsivity are observed. Further contributing to the worsening of their condition are the health issues and the physical pain that follow the increasing weight, which become another obstacle in the management of everyday life and to the achievement of one's well-being. The management of negative experience through food become a way to bear the effort of a daily life lacking satisfaction and pleasure in the absence of other more functional coping strategies, with the consequence of maintaining excessive weight. Lost all hope of losing weight through their efforts and fed up with fighting, patients come to the bariatric surgery considering such procedures their last chance to lose weight and sometimes the only way to regain their self-esteem and psychological well-being. They develop a tendency toward passivity and lose confidence to their agency along their bariatric journey. Their attention often lead them to focus specifically on some information provided by professionals like advantages of the surgical procedures, wait list, and recovery time. Less attention is paid to other equally important factors, such as risks, consequences, and side effects of surgery, dietary behavior to follow before and after surgery, the introduction of regular physical activity, and overall healthy sleep habits, moderation of alcohol consumption, and smoking. With regard to their personal commitment, for example, diet and physical activity, there is an hyper-focus on potential obstacles that make the required activities difficult to perform. Daily commitments, working hours, family or child rearing, etc. All potential valid reasons. However, what is implicitly lost amid this justification is the very perception that their health and well-being are values to be preserved. Further, it should be emphasized that along the pre-surgical journey, patients receive a lot of information from different professionals. In some fragile patients, this may create a working memory overload, difficulties in information processing, and misunderstandings, contributing to the creation of not entirely realistic expectations regarding the surgical outcomes. For example, when they receive information on the effect of sleeve gastrectomy in reducing the sense of physiological hunger, patients do not consider the fact that what made them fat was more frequently hedonic hunger, evoked by emotional eating, which does not depend on granularizing cell at the bottom of the stomach. Yet, as well known after nearly 40 years of bariatric surgeries, the story is more complex. In fact, surgery is not an easy way to lose weight, and after the first post-surgical period, also called honeymoon, for some patients who have fallen back in their difficult and stressful daily lives, the dysfunctional behaviors that previously managed stress and reduced everyday frustrations are reactivated in a non-entirely conscious way. The result is that many patients do not achieve adequate weight loss after surgery or regain weight over time, with the risk of being forced to undergo a reduced surgery. along with possible hormonal or metabolic causes, inadequate weight loss and weight recovery often depend on non-adherence to diet, physical inactivity, the presence of cognitive, behavioral, or psychological problems, or lack of support. For these reasons, to reduce the risk of weight regain and insufficient weight loss, it is important in our clinical practice to encourage patients to play an active role within the journey, both before and after surgery, helping and motivating them to create a realistic expectation about the relation between weight loss, thinness, and self-esteem, particularly in childhood obesity. To pay attention to lifestyle changes and the healthy behaviors to maintain over time. To monitor their behaviors in a reflexive way and not to succumb to negative thoughts about themselves or their attitude to unhealthy behaviors. To develop more functional coping strategies which respond to the real needs of the moment. To adapt to and accept the changes induced by bariatric surgery regarding their body and everyday lives, and to resist the urge to give up, and to stay committed to the long-term follow-up program. In conclusion, bariatric patients need to reinforce the idea that they have agency and play an essential role in the management of their well-being, and not only weight-wise, and to internalize that failure is a common experience and not a fault. Thank you.
Yeah, thank you very much for the presentation. We're going to take questions after the next speaker, if that's okay.
So let me introduce the last of the invited speakers for today, Leah Schumacher from USA. She is a clinical psychologist, assistant professor at the Temple University, and she's also a winner of the IFSO scholarship. Leah?
All right, and can you hear me okay? Perfect. So thank you very much for inviting me to speak. It's a pleasure to be here, and it's a fun session to participate in. I think you'll see some common themes. And I have no conflicts to report. So when we're thinking about metabolic and bariatric surgery, there's various outcomes we can focus on. There's things like safety and complications, improvements in comorbidities, patient satisfaction, impact on quality of life and well-being. But often big ones that we're focused on are changes in weight and adiposity. And this makes sense. This has long been a major metric for success in terms of outcomes of surgery, and it's outcomes that patients, providers, and payers tend to care a lot about. And then when we think about what impacts weight outcomes, again, there are various areas we could focus. Given that we're at an integrated health section, I'll assume that many of you have at least some interest in the lifestyle behavior category. And as a clinical psychologist, that's often an area that I'm focused on. So just a bit of context about myself. So I'm a clinical psychologist focused on obesity management or weight management. And then I also conduct research focused on obesity intervention and physical activity intervention. And I've worked with bariatric patients in a variety of settings, including general behavioral medicine clinics where people may be coming in for a variety of reasons, as well as specialty weight management and surgery clinics, as well as clinical research studies. And what I'm going to talk about today are some lessons I've learned around helping patients increase their physical activity. And what I've learned from patients cumulatively is that while we may have a tendency to default to thinking about physical activity promotion in the context of weight loss outcomes, given those very reasons I just mentioned, I'm not sure that's always the most helpful approach in terms of helping patients make changes in their behavior. So instead, what patients have taught me is that focusing on things like the ways that physical activity can improve outcomes like energy and mood, or focusing on ways that it can improve other aspects of their life that may seem very unrelated to weight or to health, is often a much more useful approach. And really the patients I've worked with who have been the most successful with becoming more active and keeping that up over time
are not doing it for the weight. They've really had to find some other reason or some other benefit to make it feel worth it. But looking to the research just quickly, given that I do also wear that researcher hat, and given that patients and providers may often be coming into these conversations with weight on the mind, what does the research tell us about physical activity and weight outcomes? So observationally, patients who are more active do often have greater weight loss after surgery. When we look at the experimental literature, which is primarily comparing people who receive an exercise training intervention to those who do not, there have been a variety of reviews. It's a little bit mixed. So some have found that patients who receive exercise training do lose about 2.5 kilos more weight. Although when we look at longer term, so at least 12-month follow-up, Bond and colleagues recently found that there was that difference, but it was not statistically significant, so it could have been due to chance. So sort of the take-home is that greater physical activity does appear to likely relate to better weight outcomes after surgery, at least during that first year, and perhaps beyond. We don't have a huge amount of data to go from. So what's the problem then? Well, as you saw, on average, the amount of additional weight loss patients can expect to experience from being physically active is fairly small. And for many of the patients I've worked with, a couple kilos extra may not be particularly motivating when they're trying to make this lifestyle change. Second, it's probably more of a long-term effect. So even if patients are becoming more active week to week, they may not be seeing a major change on the scale. And if the main thing they're focusing on is weight and how physical activity is going to impact weight, that could be quite demotivating. And from a behavior change perspective, generally we know that short-term consequences or short-term outcomes tend to be more motivating than very distal or long-term outcomes. And then third, and many of you may relate to this, many patients may find physical activity quite effortful or unenjoyable. Actually, all people, not just patients, may feel that way, but especially if people are carrying excess weight. So when you combine that with those first two challenges, that can make it feel like a large task to make this change. Yet, we know that physical activity can help support weight outcomes after surgery, and maybe even more importantly, it has many other health benefits, so improving metabolic health, brain health, skeletal health, just to name a few. So generally, this is a behavior that we're wanting to promote among our patients, and many of them want to engage in as well. So to recap, when we're thinking about what might be motivating patients to change physical activity, many people may come in with weight on the mind, and that probably will still be one motivator. But my work with patients has taught me that if that's the only motivator, that's probably not enough. So then moving into sort of what I've learned through my work with patients and how that's changed my approach. So one thing that I've found to be very helpful is focusing on those more acute benefits that people can get. And for this talk, for the sake of time, I've focused on energy and mood, though certainly there could be others as well. So again, just quickly looking to the literature. So a variety of studies have shown that greater physical activity in this population is associated with improvements in things like energy and fatigue, often measured as part of health-related quality of life. And those relationships seem to be independent of amount of weight loss. So for example, in one study I helped with, where patients wore a physical activity sensor and then completed multiple time per day surveys on a smartphone about energy, attentiveness, and fatigue, we found that on days where patients were more active, they also reported greater energy and greater attentiveness, independent of weight loss. And then when we think about mood, things like positive mood, negative mood, stress, again, looking at the broader literature, physical activity can have positive effects on all of those outcomes. But maybe more powerful, looking to patients' experiences, I've found that when patients can kind of tap into those different benefits and really focus on the way that they that physical activity changes how they feel, that can be very reinforcing and motivating. Sometimes to the point where people are very surprised. So a couple of patients I've worked with, once they've gotten a routine built up, they've found that physical activity becomes one of their core strategies for maintaining their mood, certainly with energy, for feeling like they have sustained energy, to the point that many of them would not have expected and have even said, I've never considered myself an exerciser, and maybe I'm still not a competitive athlete, but I find that it helps me feel so much better. A couple of caveats. So of course there are individual differences. Some people probably will never love exercise, and it might take some exploration to figure out what type of activity, the time of day, the type of environment where people are going to notice the greatest boost in those different outcomes. For most of us, we're going to feel better after exercise than during it, and I think orienting people to that can make a big difference, because if they expect to feel excellent every moment of exercise, that again just may set up an unrealistic expectation. If that happens to be the case, wonderful, but I think it's probably more the exception than the norm. And then there's, I think, a sweet spot for intensity. So to get benefits in mood and energy, it seems that we need to be doing exercise at an aerobic level, but if we move into that vigorous category, then it may become more unpleasant. So kind of working with patients to figure out what threshold really helps them feel those positive benefits that can then help them sustain the behavior change. So one lesson has been focusing on outcomes that may seem at first less related to surgery, but I think much more helpful for behavior change and for improving patients' well-being and motivation. A second thing I've learned from my work with patients is that it's really important to step back and look at the bigger picture. So what would physical activity get them? So really we can think about this as finding the why, and this is something talked about in a previous presentation as well in terms of values. But I think, as providers, we may put a lot of value on better health or good health, and patients likely do as well. But I think it can be a bit of a slippery motivator because it's kind of this nebulous concept, and patients, when they're living their lives and have a lot going on, it can be hard to pin down what that would actually mean for them. So instead, thinking about questions like, what would physical activity or improved health actually do for them in their life? Or what other things do they care about that may seem unrelated that actually do connect to physical activity, and physical activity can help make better. So to give some examples, maybe a patient really wants improved mobility so that they feel like they're better able to play with their kids or their grandkids if they're crouching or carrying them. Maybe for some people, they're really wanting better fitness so that they feel better just doing activities of daily living, or maybe for things like travel. For others, maybe they find it really powerful to feel like they're a positive role model for other people in their life, and being physically active and practicing these behaviors lines up with their sense of what a positive role model could be. Or for others, maybe physical activity is a way that they can explore different aspects of the world, whether that's nature or some other activity, or meet other people. But things that don't necessarily directly tap into health, but when you zoom back, will still give them benefit in that domain as well. So one approach I've often used, and I think patients often find very helpful, is acceptance-based intervention, or ACT, as it was previously referred to. So this has multiple components, but generally the key focuses are really helping patients clarify their values, so what it is that they do care about, whether that's parenting or the performance at work, and seeing how that does connect to health behaviors, with the goal being to help that then motivate them in those areas. I'm helping make those values more salient in daily life. When we're busy, when we're stressed, even if we know we care deeply about these things, they slip from mind very easily. So figuring out ways that people can kind of keep that connection at the forefront of their mind, and then also using mindfulness and acceptance-based skills to help people overcome different thoughts and feelings that otherwise might get in the way, even if they have this very clear sense of the why. And so, the ACT-based interventions do have some research support, and some colleagues and I are currently hoping for funding to continue looking at that intervention strategy among patients, bariatric surgery patients. But you could also do this more simply by kind of the key elements of really helping patients identify the big picture. So what are people's big values? Really setting aside health, weight, and then secondly, making that important connection, how might physical activity enhance those things? So the second big lesson is seeing if or how physical activity connects to the things that patients really care about in their life to make that why salient. So just to wrap up, I think one big takeaway from my work with patients is weight is probably part of the picture when people are trying to make lifestyle changes, but hopefully it's part of a larger picture. And I think that we can support patients by, in our conversations, helping orient them to the other benefits that they might get, so that weight doesn't become a myopic focus that maybe isn't quite as helpful when they're trying to make these changes day to day. So focusing on short-term benefits like improved energy and mood, and then making those connections to the broader areas of life, or the why. So I'll stop there, and there's contact info. Thank you.
Thank you,
Thanks.
Leah. That was a wonderful presentation. And now we'll take the question answers in the discussion.
Sure. Does the panel want to come up here? That would be great. And just to let you know that we actually have two advocates in the audience who have the lived experience of bariatric surgery. So they might want to either ask questions or answer questions. So we've got those as well. So come up. Yeah. If the speakers could come up here, that would be great. Thank you.
I think it only fair that we're talking about patient experiences, and what we've learnt is whether or not I can invite Ken and Dana and put them on the spot and say something.
I think there were some excellent takeaway messages from the whole session today. My name's Ken Clare. I'm chair of the European Coalition for Obesity in Europe. And this is...
My name is Diana Castillo from HCPO.
And some of the real things that blown me away from the session this morning was Andrea's approach around the retreats and the Generation X talk. And I think that there's some of the Generation X in all of us. And sorry, Generation Z, I'm out. But I think there were so many take-home lessons, and physical activity is such a difficult subject. But a great session for us this morning.
Thank you.
Hello, can you hear me? Yeah. Hi, Eugene Romano, King's College London. I enjoyed all talks, really great. And I have a question for Dr. Schumacher. So I'm very interested in stigma, and we all know that it can be a big barrier for physical activity. I wanted to ask if you have some information on how patients can work around this. Like, do you know anything about whether they prefer to work out alone, work out in a gym, work out at home, or maybe in a group to feel motivated, something like that?
It's a great question, and I think that it is, for many people, a big barrier. In my experience, I think it very much depends on the person, but it's worth having that conversation. I think some people feel very intimidated by gyms, particularly if they're unsure how to use equipment or they feel that others are looking at them. So in that case, finding a more private setting might be preferable. For other people, they want to be in a group with people that they feel are supportive, so then it's finding the right group to be with. So maybe they, at least at first, do not feel comfortable going to a group exercise class with just anyone, but maybe there's like a group that's specifically designed for people who are just starting to become more active, and that feels more safe. So I think it's a little bit knowing oneself, but I do think it's very much worth asking about. Not everyone will bring it up. So as a provider, that might be worth specifically asking, and if for them it's not relevant, they'll likely tell you. But I do think it can be intimidating, and people can feel very self-conscious. So thank you.
Thank you.
Hi, excellent presentations. For Dr. Schiff, lifestyle interventions themselves do not have great long-term data of success. You advocate making sure that those lifetime changes get added on and don't get neglected in bariatric surgery, after bariatric surgery, to deal with the hedonic rewards and other. But adding something that doesn't have great success onto something else, do you have data that suggests that the patients who do both do better?
No, I have not a lot of data, but for me it's essential to stimulate patients to work by themselves for their lives, for their quality of life, together with the medical approach. But lifestyle is the history, is our evolution, and the changes in the last 40 years regarding our environments that is changed produce the increase in obesity. Obesity is not a problem only of the modern life. There is obesity problems in physiological aspect that can create obesity. But lifestyle is for me is a value for not only for obese patients but for all of us. And there is also a discussion about a conflict of interest. Sorry, I have to say, because clinical trial for psychotherapy or lifestyle changes give not money to anyone. And this is a problem for me because, you know, pharmacology is supported, surgery is supported, psychotherapy, clinical trial on psychotherapy and lifestyle intervention are not a lot supported. And this is a problem. In my point of view, this could be a problem in generating good data and and also to invest in this type of research. This is why there is not a lot of data. But for the quality of life is the main objective of every intervention, both physical, medical, surgical. Quality of life is the end point of our work, in my opinion.
Yeah, my quick question to Radhika. You have mentioned NSRK in your presentation. So what was the measure you have used to assess? Just by looking at the patient, or like you have used some measures?
Yeah, very interesting question. So anasarca, is a fluid retention all over the body. It is different from normal edema that we talk about, and it is clearly seen. Anasarca is typically a cellulitis which can be seen like a hard stony skin, black pigmentation, cellulitis, kind of pictorial representation. It can be easily seen. However, we do some in some patients we did the assessment and even the lot of fluid retention which is seen and sudden weight gain. In one of our patient, a patient had gained almost 30 kgs weight in 6 months. It represents or it indicates that there is something abnormal. It's not just the fat, but it could be fluid retention which can give rise to such a massive anasarca. Yeah, and we also do some investigation to rule out, because anasarca and lot of fluid retention can also be related to subtle renal or heart failure. So even both of them, the parameters like NT-proBNP, etc. should be assessed in such patients.
Thank you, nicely answered. And very nice presentation. I'm really impressed. My only observation is like, and I want to congratulate the IFSO who have took this subject to this platform, because many things we have learned from our patient, irrespective of how much knowledge we have gained before entering in this domain. So just a simple thing like the patients in initial phase, hydration is important and patients are not able to drink water, plain water. How to modify that? These are the small things we have learned from our patients. So definitely such initiative should be always taken by the such congress, and I have personally learned a lot. My only submission to your presentation is like obviously like the age you have shown the cutoff up till 2010, but now we are in a 2023, and if we are dealing with the adolescent people who are very well connected to the information technology and all, then our challenges goes up double the normal one, and at the same time their requirements are much different than the adults. So it is very challenging phase. They should be treated differently, not the way we treat the normal adult people. And you have mentioned in your slides like we shouldn't take it as a normal guidelines for these patients. We require to give a personalized care. Thank you so much.
Thank you.
No other questions? Any more questions? If not, Andrew can close the session, but what I've got is an important thing, is actually to tell you coffee is in room 5, exhibition area 5. Sorry, did you have one last? Yeah, and then go.
Hi, my name is Ness. I'm one of the specialist dietitians in bariatric surgery from Chelsea Westminster Hospital, UK. I personally have a question for the Gen Z presentation, which I really liked, and this is the current situation we are facing at the moment. We recently had a case with a patient who basically, this is more like not after the surgery, but before the surgery. So in the setting that we are working in our hospital, it's more like NHS setting, and we have to clear the patients before going forward with the surgery. So what we experience with some of the Gen Z patients, the way that they report, that they kind of, to be cleared for the surgery, they just say everything that we want to hear from them. And how do you deal with those type of situations? So how do you get down to the bottom of, are they telling us the correct thing or not? Because then after surgery, what happens is that they face quite a lot of challenges. So before the surgery, what type of approach you might do in your counseling sessions with them?
Thank you for your question. I think it's an excellent question. First of all, I think now that you were talking, it hit me that maybe we should even just change the way we assess and just make different assessments for maybe the younger populations. I think counseling strategies and just different counseling models have to apply for this generation. So. Personally, in my practice, first of all, I really try to build a really good relationship with them. So I take, a few sessions to kind of build rapport with these patients. I highly recommend also sitting with them individually because a lot of these patients, especially the young ones, usually are accompanied by a parent or a caregiver. I highly recommend sitting with them alone, having a conversation, because this is when you try to understand. As I said, the patient who I told you the story about had always been with his mom throughout the entire counseling before and after surgery, and I never actually sat with the patient by himself. So I highly recommend alone time with the patient. Not that having the parent is bad, but it's just, it really brings out a lot of the honesty. Also, being like, just changing the attitude and not being so parenty with them. Really try to get down to their level and make sure that you really understand and be very compassionate with the struggles that they face and be really understanding. I think that's, I guess, the key to handling this patient population.
I know there are a couple of people who want to ask more questions, but I think we need to close because everyone needs to keep hydrated. But I want to give a special thanks to all the speakers, excellent presentations, and also all the moderators as well, and actually the audience, because it's, you know, it was hard getting here for the time, and you all made a great effort, and it's been a great symposium. So thanks for interaction as well. Thank you.